Good morning, everybody. We're going to go ahead and get started. Happy Tuesday morning to you. My name is Micah Olson. I'm a pediatric endocrinologist here at Phoenix Children's. I'm also the director of the CME department. So most Tuesday mornings, it's my pleasure to come up here and introduce the speaker. But today I have the distinct pleasure of introducing myself to you because I'm the presenter this morning. So thanks for coming. By way of prologue, I wanted to spend a few minutes talking about a man by the name of Francis Bacon. Does anybody remember, deep from the recesses of your high school and college history classes, who Francis Bacon is? I would be very impressed if you did. So Francis Bacon was an Englishman, lived in the late 1500s and early 1600s. And he is really credited as being one of the fathers of modern science. He's specifically known as the father of the inductive method of science, and really is one of the major architects of the scientific method that we know and think of so often today. This method that's kind of ingrained in all of us of making observations of the world around you, forming hypotheses, and testing those hypotheses. That very much had its origin with Francis Bacon. And in spite of his huge endorsement and drive to understand more from the world around us through investigation, he had what he called 4 idols of the mind, which were basically warnings to people as they were making investigations, making observations of the world around them, and forming new knowledge from that. And he recognized that as humans, we don't always see things clearly. And these 4 idols of the mind represent 4 ways that he thought we could kind of err in how we interpreted data. All 4 of them, I think, are highly relevant to us today, but I want to call your attention to the second one, what he called the idols of the cave, the idol of the cave. Basically, what it means is that all of us have our own biases. All of us have our own ideologies, and we see the world through those biases. And so none of us see life clearly through a filter that is neutral or unaltered by our own bias. And an illustration of that bias, or illustration of this idol, he wrote this, and I want to just read this to you. This is a quote from one of his famous works, The New Organon, in 1620. He said, "Human understanding, when it has once adopted an opinion, draws all things else to support and agree with it. And though there be a greater number and weight of instances to be found on the other side, yet these it either neglects and despises, or else by some distinction sets aside and rejects, in order that by this great and pernicious predetermination, the authority of its former conclusions may remain inviolate." I absolutely love that quote. Every time I read it, I think I love it more and more. And I think, for sure, I'm sure that was true in 1620. But I would suggest to you that that is true in spades today in 2018. So each and every one of us sees life through a filter. Each and every one of us is biased. I am absolutely, as the presenter today, biased in presenting this material. And I just want to acknowledge that before I get started. So I think it's true of the human condition that believing is seeing, not the other way around. Believing is seeing. What I mean by that is all of us see what we want to see. All of us have our biases. Let me say one more thing before I dive into the material. We're going to be talking about nutrition. Nutrition is a very, I think, emotional topic for everybody. I'm going to be presenting a number of data to you. And just want to say from the outset, I think the data in nutrition, for one, it's extremely hard to do this science for reasons that have been well documented elsewhere. We can go over those reasons if you want to today. But it's extremely hard to do nutrition science. And I think the science is muddy. And obviously we're not going to clear up the science in the next hour of the talk. But be that as it may, every person has a lot of reasons to eat the food they eat. Science and health is one of those reasons. I think there's a lot of other very legitimate reasons for us to eat what we eat. So if you want to talk about economic reasons, cultural reasons, family reasons, national and ethnic reasons, moral and religious reasons, I think all these are very legitimate and just as legitimate, if not more so, than what the science says. And the science, as I said, is quite muddy on this. And so personally, as I see patients, and I do talk about nutrition a lot, whether it's in the context of type 1 diabetes or in the context of obesity and trying to lose weight and trying to improve cholesterol and so on and so on. I think it's very important to take all of these, all of those reasons that people have, those very legitimate reasons for why they want to eat the way they eat, and put them not necessarily inferior to what the science says about this. All right, so let's dive in. In 1977, the US government made recommendations, very comprehensive set of recommendations on diet that really formed a first for the US government. They called it the Dietary Goals for the United States. And this subsequently turned into an every 5-year process that they called the Dietary Guidelines for Americans that they publish, 1980, 85, 90, and so on and so on. The last ones were introduced in 2015. And we're going to come back to these guidelines, but when they were published in 1977, it really represented an accumulation of a couple decades of work and belief in this area, and it very much changed how we ate as Americans. They recommended that we increase carbohydrate intake to 55 to 60% of calories and to decrease dietary fat to no more than 30% of calories, with a reduction specifically in saturated fat, and that we decrease cholesterol intake to 300 milligrams per day or less. There are also recommendations on sugar and salt intake. It's had a drastic effect, as we'll see in a few slides, on the way that Americans eat. And it really has been called a vast, uncontrolled experiment on the American diet. It was controversial at the time, and there's been somewhat of a renaissance of the controversy in these recommendations over the last several years. And I want to go through the story of where these guidelines came in the first place and why they've become increasingly controversial in recent years. This demonstrates, this is from NHANES. This is every few years they do a survey, CDC does, of Americans and their macronutrient intake. Just very briefly, kind of a nutrition science 101, there's 3 main macronutrients that contain calories: carbohydrates, fat, and protein. And all of our diets contain some degree of these 3 forms of calories. But you can see there, after the recommendations came out in 1980, there was a clear increase in carbohydrate, or the amount of calories that we receive from carbohydrates, and a clear decrease in the amount of calories that we receive from fat. And that's true in both men and women. The men is on the left, the women on the right. I didn't see data that extended all the way to today, but I did see data that showed from 2000 to 2010 and beyond. And really by that time, the lines become very flat. There has not been major changes in the percentage of calories we get from various carbohydrates from that time. But really from 1980 through 2000 is when the major changes take place. And during this time, there's also a clear increase in calories consumed as well. So total calories is increasing, and then this just represents the breakdown of those macronutrients. So why did we get this idea that fat is potentially bad for us? It comes from a line of thinking that really these first 2 points are not argued by whatever side of the argument you come on, whether you are a proponent more of lower fat versus lower carbohydrate diets. These 2 statements are generally well agreed upon, that increased dietary fat leads to increased total cholesterol, and increased total cholesterol is associated and predictive of increased cardiovascular disease. So if you put those two together, it is a tempting next logical step to say, okay, so if we can decrease our dietary fat, will that lead to cardiovascular disease, to decreased cardiovascular disease risk? And that was the question that was prominently answered, or asked in the 1950s and going forward. So this has had a long history in our culture, and it remains something that the lay media is highly interested in. I think that's always been the case. This is a series of Time covers going back to the 1950s. This is Ansel Keys. We'll talk some more about him as we go on. He was a pathologist from Minnesota who definitely cut a wide swath in his day. This is a cover from the 1980s, very much the peak time of cholesterol and fat being bad for you. And then this is a cover, you may have seen this. This gained a lot of notoriety just a couple years ago in Time magazine. The headline there is, "Scientists labeled fat the enemy, why they were wrong." So very kind of controversial and headline-grabbing covers here. I think just illustrates our fascination in the public with this topic, and in that this has been in the culture for a long time. So 1950s, the context here, historical context is post-war, and there are increasing rates of cardiovascular disease and cardiovascular death in America and in other Western countries. And people really didn't know why. There's still enormous controversy on how and why this occurs, but people were really wanting to grapple for the first time as the incidence was rising on what was causing this. There was a number of different theories, and into this mix comes a theory that possibly it's dietary fat. And so this pathologist from Minnesota, Dr. Ansel Keys, did a study that gained a lot of notoriety and continues to gain notoriety today, called the 7-country study. It was a prospective cohort study. It went into 7 different countries and did initial surveys on dietary habits, and then looked at a number of different outcomes, but most focused on cardiovascular disease and death over time. And in these 7 studies, he showed an association between how much fat, and specifically saturated fat, that the average people in the country ate and death from cardiovascular disease. Now, this study was the impetus for what he called his dietary heart hypothesis, and a number of future studies that tested this on a randomized control level. This was obviously just observational data, and he was very clear to point out always through his life that you cannot assume causation from this, that you can only assume correlation. Of course, we all know that that's true. And so they did do studies, and we'll review some of those, to look at more of a randomized control trial where we try to infer causation, and you can better infer causation. But this was really, in large degree, the impetus of that from a scientific standpoint, and just in the lay culture as well. This study has been heavily criticized, both in the day and currently. And there are a number of popular books and so on currently that go through a report of in summary of the criticisms of this. I'm not going to spend a lot of time going through those today, but largely they involve, one, how he collected the data and some of the rudimentary ways that they were able to understand what people were eating at the time. This is the 1950s. And then 2, just how he selected the countries. He did have some preliminary data on a much wider number of countries than just these 7. So why did he pick these 7? The classic thing is, he left out France, and France is notorious for, famous for having higher fat diets and lower cardiovascular disease. Other European countries, Germany, or what was then West Germany, same thing. And so there's a lot of back and forth on some of those questions about how he picked or potentially cherry-picked these countries to show what he wanted them to show. Be that as it may, this idea was really adopted in the mind of American culture and in science as time goes on. And I want to show you some of the follow-up studies as they develop randomized controlled trials to test this hypothesis that it's fat that increases risk of cardiovascular disease. So this was a study published in JAMA in 1966 called the Anti-Coronary Club Program. This is one of the early studies. This was a controlled experiment, but it was not a randomized controlled experiment. They took 814 men from the New York area, placed them on a low saturated fat diet. Then they took a control group from a completely different group of men. It's 463 of them, recruited them from a different source. And the intervention, of course, was to decrease dietary intake of saturated fat. They didn't really change the amount of fat they were eating. The purpose of this study was to look at saturated fat specifically. So what you'll see as a theme in a lot of these studies is the lower saturated fat or the lower fat intervention clearly decreases cholesterol, as everybody acknowledges that it would. And in this group, the experimental group, the group that got the lower saturated fat, went from 260 to 225. This is total cholesterol. They did not have at this time the subclasses that we do today of LDL and HDL and on and on. The control group baseline was around 250 and stayed at 250 through the course of the study. And in fact, in this group, there was a decreased rate of MI in the experimental group. But something that they really don't spend a lot of time talking about in the study as you read it is that there were 27 deaths in the experimental group and only 6 deaths in the control group. And to be fair, there were more people, more men in the experimental group, but not nearly enough to explain the increased amount of deaths. They did not report mortality in the same way that we do today in Kaplan-Meier curves and those sorts of things. Looking back, it's interesting, in 1966, the methods they have of reporting this data. But obviously, there was a higher rate of death in the experimental group despite the decrease in, the effective decrease in cholesterol. That the increased rate of death is, they didn't really focus on that, and that's a theme as we'll go through several of these other studies. Really, the take-home that you see in the literature from this is that it was effective, the lower saturated fat diet, in decreasing cholesterol. Therefore, it was a success. I want to point out one other thing, that the 7-country study was looking just at men, and a lot of these early studies were looking solely at men, this one included. Another one that's looking just at men, this is a much larger and better controlled, this is an actual randomized study here. They called this the Multiple Risk Factor Intervention Trial, or the Mr. Fit trial. It's had nearly 13,000 men at baseline. They took men who are at the highest risk based on their Framingham risk score calculation of cardiovascular disease. In this study, they did not have just one intervention as they did in the previous study. They threw 3 main things at them. In the intervention group, there was an effort to decrease cigarette smoking, an effort to treat hypertension, and dietary advice given to lower cholesterol, again, to decrease saturated fat. The control group just got usual health over the course of the study. They saw their primary doctors and didn't have anything different. The average follow-up period was 7 years, so a much longer study than the previous one. In this study, here's a comparison of some of these intermediary mediators in the 2 groups. So clearly, SI is the intervention group, UC is the usual control. So blood pressure, which was controlled aggressively in the intervention group, clearly goes lower over the course of the study. Total cholesterol, they were effective at decreasing total cholesterol. Cigarette smoking, reported, clearly successful at decreasing that. And then the thiocyanate, it's a blood level that they were able to document or confirm that cigarette smoking actually did go down. So clearly lower in the intervention group. So those are things that, especially the decrease in smoking, the decrease in blood pressure, very clearly associated with decrease in cardiovascular disease and deaths. But what they found in this study, this very large and longer-term study, that there was actually no statistically significant change in rate of coronary heart disease. It was very similar in the 2 groups. And the total mortality rates were, again, no statistical difference, significant difference. It was actually slightly higher in the intervention group. So there were 3 main things they were studying. 2 that very wide consensus that are very effective at decreasing mortality and decreasing cardiovascular disease, both cigarette smoking and a decrease in blood pressure. And then one that is heavily argued to this day, decreasing the dietary saturated fat. So again, the take home from the study was that this study was successful. It this diet successfully decreased cholesterol, therefore it's a good thing. And they really there was some disappointment that the total mortality rates weren't better, but they didn't spend a lot of time discussing that as you read through the paper. So another famous study, the Minnesota Coronary Survey. This was a randomized controlled trial of men and women in mental hospitals in Minnesota. So there's a number of ethical issues with the study that would make it such that they could not repeat this today. But not only was this a randomized controlled trial, but this was a double-blind study. If you think about it, it is enormously hard to do a double-blind nutrition study. But because they were in institutions, they actually fed the different participants, whichever arm they were on, a meal that looked, as they did their best to make it look exactly like the control meal. And a lot of effort was put into, there was about half a dozen institutions where this was done, and each participant, whether they were in the control group or the intervention group, they had a number, and they would go through the line in the cafeteria in this institution. They would give the cafeteria worker the number, and that number would tell them do they get the low saturated fat meal or the high saturated fat meal, and they were cooked to look exactly the same. Primary outcome here was cardiovascular events, cardiovascular deaths, and total mortality. And again, this diet was highly effective at decreasing serum cholesterol in the treatment group. Went from 207 at baseline in both groups down to 175 in the treatment group versus 203 in the control group. But despite that improvement in cholesterol, there are actually no differences between the treatment and control groups for cardiovascular events, cardiovascular deaths, or total mortality. That was highly disappointing. This is one of the largest studies. I've seen some reports that it was kind of the largest well-designed, randomized, well-controlled study. There was deep disappointment that they did this well-designed study. It did not see any improvements in outcomes. So much so that they actually sat on this data for 16 years or so. The study was ended in 1973 and was not published until 1989. And one of the study authors is on record. They asked him why did they wait, and he simply said the study results were very disappointing to them. So there's been, in the last few years, some reanalysis of some of these older studies, and this came out to a lot of press in 2016, a reevaluation of the Minnesota Coronary experiment, where a gentleman went back and looked at all the files that they had from this study and kind of put the results more in modern terms as we understand them and are reported, as data is reported in a lot of studies today. He showed from this that the intervention group, same findings, had a significant reduction in serum cholesterol compared to the controls, and again confirmed that there was no benefit for the intervention group for mortality, for atherosclerosis, that was by autopsy in those who had died in the course of the study, or an MI. Further, he found that the more you reduce cholesterol, the higher the risk of death was. So for every 30 milligram per deciliter reduction in serum cholesterol, again this is total cholesterol, there was actually a 22% higher risk of death in this study. A similar reevaluation was done on what they call the Sydney Diet Heart Study. It was a much smaller study done in Australia, but very much same idea. Two groups, one with less saturated fat, one with more of a control diet, and really saw the same thing, that there was not only did they decrease cholesterol in the intervention group, but there was no improvements in their outcomes, and actually in that study was a higher rate of MI and death in the intervention group. So most of these have been on men. There was a very large effort to now look at this in women. And you've probably heard of this. There were a number of different outcomes looked at in the studies called the Women's Health Initiative. It's a randomized control trial of nearly 50,000 postmenopausal women aged 50 to 79 years. And the control group, the intervention group in the study was intensive behavior modification, dietary modification designed to reduce total fat intake to 20% of calories and increase fruits and veggies and increase grains to at least 6 servings per day. The control group got diet-related education materials and just usual health care. And this study had a mean follow-up of 8 years. The primary outcomes in the study were, they were looking at rates of cancer, but clearly they also had in mind as secondary outcomes cardiovascular disease. This study, at the end of it, again, deeply disappointing to those that really were hoping to finally see some data that would affirm the diet-heart hypothesis. But there was no reduction in incidence of cardiovascular disease or stroke, no reduction in incidence of breast cancer, no reduction in incidence of colorectal cancer. Now, there were trends both ways. I think for the breast cancer, it was slightly lower in the intervention versus the control group, and for colorectal, it was the opposite. But I might have that opposite, but either way, in none of these enormously large studies was there a statistical significance in the results. The weight, in fact, was slightly higher in the control group, and it was statistically significant, but it was actually a 1 kilogram difference. And because it was a study of nearly 50,000 people, that 1 kilogram actually became statistically significant. But I think very questionable whether that's clinically relevant, and especially when you throw all the resources and materials at the intervention group that they had to see at the end of this a difference of 1 kilogram is I took it as quite impressive and interesting. That should we go back and look at this hypothesis. So that's I want to kind of move forward now and talk about how these guidelines and how just our modern diet has changed as a result, what some of the consequences have been, and what some of the more modern studies, both observational in population and interventional randomized control trials, have shown. So again, I showed this slide earlier. This is the enhanced macronutrient intake, showing the clear increase in carbohydrate intake in both men and women after the first guidelines were published in the late 1970s. And you guys have seen these types of graphs before. This is a graph showing CDC NHANES data of obesity and overweight rates in men and women over the last few decades. Now, at first glance, you say, well, the overweight really hasn't changed much. But the thing is, you can graduate from overweight to something worse. So the overweight in men and women hasn't really changed. But if you look at the obesity and then the extreme obesity, enormous increases. As everybody knows, this is not new information at all. But really starting in the late 1970s, early 1980s, and a lot of people have attributed this to the increase in carbohydrate intake in our diet. Surely there are other factors involved, and I don't want to make the mistake of inferring causation from observational data, as has been made many times before. But it's largely, nutrition clearly has a large influence on our weight and body size, and clearly these recommendations were telling us to increase carbohydrate intake. Clearly we were increasing our carbohydrate intake. And so this is interesting of the results, or how our BMI trends have been since this time. This is children data. It really shows the same thing, and what we already know is that there's been enormous increases in all age groups in pediatrics in rates of obesity over the last 30 to 40 years. So the people that have been heavy in making the guidelines on the NIH level and the AHA level, and there's a lot of overlap there. A common defense is that, well, we didn't know that everybody was going to increase sugar intake. But the AHA has what they call a heart-healthy food certification, and for a very steep price, if your food meets certain criteria of being low fat, you can buy from them this certification and put it on your product. And it's a huge source of revenue for the AHA, and it has been historically on cereals like Fruit Loops, like Frosted Flakes, like Cocoa Krispies. And over the last few years, they've kind of wised up and taken it off these types of cereals. But just show this to say it does, to me, at least ring a little bit hollow, kind of saying, well, we didn't know what was going to happen. We didn't know that, we weren't telling people to increase sugar intake, and at the same time endorsing these types of foods as heart healthy. So I want to kind of go through current averages and compare them historically for both adults and then the next slide to kids of carbohydrate intake. So as I've said, our total calorie intake has increased over time, but even within that increase in total calories, clearly it's been, the percentage has gone higher from carbohydrates. So back in 1970, the average carbohydrate intake for an adult male was 252 grams of carbs. That has increased today to 325 grams of carbs daily. For women, they now consume 52% of their daily calories from carbs. That's gone from an average of 169 back in 1970 to 247 today. For adolescents, this is all from NHANES and CDC websites. Both adolescent males and females consume about 55% of daily calories from carbohydrates. Again, that's a significant change from previous decades, and the average for males would be about 358 versus 248 for adolescent females. And this graph, or this slide shows our body's response in terms of insulin production to various to various macronutrients. And it's clear that carbohydrate has the biggest impact on our insulin production, protein and intermediate, and fat very little. And you guys remember from physiology, what does insulin do in your body? We know it decreases blood sugars, but how does it act? Is it an anabolic hormone, or is it a metabolic or catabolic hormone? Is it increasing storage, or is it utilizing energy and decreasing your energy stores? Insulin absolutely increases your storage. It's the fed state, and as you eat meals that are rich in carbohydrates, you are stimulating your insulin production and telling your body to store fat. And so this has led to the current popular lower carbohydrate movement of people. This is one of the main mechanisms for why a lower carbohydrate diet can be helpful in losing weight, and why a higher carbohydrate diet, as we have all adopted historically over the last few decades, is potentially so prone to causing us to gain weight. All right, so I want to review some more modern data. We'll start with the more epidemiologic and observational data, then we'll go into some trials. This was a meta-analysis of all the previous dietary studies, randomized controlled trials, and observational data looking at various types of fats and their impacts on coronary outcomes, basically showing that apart from trans fatty acids, which is universally agreed, whatever side of the argument you're on, to be dangerous for health, but everything else crosses the null, as we say, means that it's not statistically significant. This is another meta-analysis looking at saturated fat specifically on various outcomes. Again, every outcome from this meta-analysis crosses the null. Again, that means it's not statistically significant, whether you're looking at all-cause mortality, mortality from heart disease, and type 2 diabetes. This is a study, the peer study that was published a year ago in Lancet. It got an enormous amount of media attention at the time. This, again, is just observational. It's a longitudinal cohort study. So you have to be very careful about the inferring causation from this. I just want to say that up front, in the same way that we have to be careful with Key's old data in the 1950s. This is much larger, we think more sophisticated ways of gathering dietary data, and this is not just 7 studies, but this is, I forget how many studies, but, or I'm sorry, how many countries, but well into the teens. Very much an international study, looking at over 100,000 individuals, and by now the average follow-up time is 7.5 years. And basically shows that the higher amount of carbohydrate intake you have, as they've divided into quintiles, the higher rate of total mortality. And the opposite is true for fat intake. The higher fat intake you have as you go into increasing quintiles, the lower odds ratio of total mortality. And this slide looks at this data a different way. This is or really the same data, but looking at it a different way. As you go into higher quintiles of carbohydrate intake, increasing rate of death, and for fat, as you go higher intake of fat, actually decreasing rates of death. And this breaks out the type of fats: saturated, monounsaturated, and polyunsaturated, and actually shows what I think is, even those who have been staunchly on the low-fat side of things would now acknowledge both monounsaturated and polyunsaturated fats are not to be avoided, are not necessarily bad for health, but the focus is on saturated fat, where there's still a large contingent that believe that to be unhealthy, versus this kind of new group saying that even saturated fat is not unhealthy. But even for saturated fat, you see in increasing quintiles of intake, you see no increase in mortality, and in fact, the opposite, a trend towards a decrease in mortality. Just want to mention this real quick. This is, again, an observational longitudinal study on milk type in children. This is by Mark DeBoer. He's a pediatric endocrinologist who's in Virginia now. He's actually an Arizona native. And they looked at over 10,000 children, aged 2 to 4 years at baseline, and actually saw, as the increasing fat content of the milk, going from skim to 1% to 2% to whole milk, you had decreasing BMI Z-scores. And clearly an increased odds ratio of being overweight and obese with the lower amount of fat in the milk versus the higher. There's been a number of other studies that have shown this exact same thing. This is the largest one I could find. Briefly on eggs. There's been a lot of talk about eggs and the dietary cholesterol intake, and a lot of controversy back and forth. But the previous guidelines to restrict cholesterol really have gone away based on kind of, I think, just the more data that has come out. This is a meta-analysis looking at a number of different observational studies. And they looked at a few different outcomes. This is ischemic heart disease, this is stroke, this is cardiovascular disease, and this is the overall here. And for all the subtotals, none of them, again, cross the null. So there's no statistical significance in any of these compilation outcomes, but possibly just a trend here to a little bit protective the more eggs you eat for all these outcomes. But you want to be careful, again, as this is observational data, and it is not statistically significant. But I guess when the guidelines are saying to decrease the cholesterol or decrease the fat to a certain amount, the onus on the literature has to be to prove that that's correct, to change our dietary habits. So I think there's really a stronger burden of proof to prove that we should be doing these things. And if anything, these studies really show the opposite. So let's review a few adult randomized controlled trials, and then we'll end with some pediatric trials. Talking mostly about adults in this talk, and there's just very much a paucity of data, especially interventional data in children. But there have been a few small studies, and I want to review those, and we'll finish with that. This is a study that got a lot of press, published in New England Journal back in 2008. It was an Israeli study. They had 3 arms in a randomized controlled trial. There was a low-fat arm decrease calories to less than 30%. Decrease fat to less than 30% of calories per day. And that was, of course, the longtime AHA recommendation, ADA recommendation, and the government recommendation. That diet was calorie restricted. The other arms, one was a Mediterranean diet, which was moderate fat and calorie restricted as well. And then there was a low carbohydrate arm in which they had, at first, they targeted 20 grams of carbohydrates daily, and then they liberalized that to a max of 120 grams per day, but still 120 grams per day is far lower than average today. That last arm was not calorie restricted, and you'll see in a lot of these randomized controlled trials a theme that the low fat arm is calorie restricted, the low carb arm is not calorie restricted. So here are the results in terms of weight. Mediterranean and low carb really do the best, way better than the low fat diet, and really not much difference between the low carb and the Mediterranean, but clear differences between those two and the low fat, which was, again, calorie restricted versus the low carbohydrate, which was not calorie restricted. This is looking at some cardiovascular markers. Now, I've told you before, it's pretty much well agreed and acknowledged that higher fats diets will increase total cholesterol. But the more we learn about total cholesterol, obviously it's unclear to what degree it's predictive. And the higher fat diets will also increase HDL, and you see that, and also decrease triglycerides. So what is the cumulative effect on our cardiovascular risk? So here you see clearly that the low carbohydrate diet has the best effect at increasing HDL, which you want that HDL as high as possible to improve your cardiovascular risk. And it decreases triglycerides the most. You'll see that as a theme in some of the studies we review. And then the ratio of total cholesterol to HDL, which is a very important marker of future cardiovascular risk, is best influenced by the low carbohydrate diet. Mediterranean is intermediate. So the Predicate Study, this was a study to look at two arms of the Mediterranean diet versus, again, a controlled diet, which was a standard AHA, ADA, USDA recommendation to lower fat to less than 30%. This was a much larger study, over 7,000 adults. This was conducted in Spain. And the two Mediterranean diets were similar, except for one was supplemented with olive oil, the other was supplemented with mixed nuts. So they actually had to stop this trial at about 5 years in due to an interim analysis showing superiority of the Mediterranean diet relative to the low-fat group in terms of cardiovascular outcomes. And this slide shows those in Kaplan-Meier curve, the improved both total mortality and the cardiovascular events on the two Mediterranean diets versus the control diet. And the Mediterranean diet really is kind of credited with being the first to change our thinking that some fat in the diet, it's not a very low carbohydrate diet, but it's clearly much lower than what has been recommended historically since those first guidelines in the 1970s. And it's a higher fat and lower carbohydrate relative to what's been recommended. And so it's kind of introduced this, it's okay to, or possibly higher fat is okay. It's another, this is just low carbohydrate versus low fat. Again, in this study, I don't want to go into that much detail with it. But the low carb group was ad lib calories. The low fat group was calorie restricted. In spite of that, you see clear superiority in terms of body weight with the low carb group. And then some of these cardiovascular risk markers, the total cholesterol to HDL ratio, superior in the low carb group. And then the change in triglycerides is clearly superior in the low carb group. That's really a consistent theme as you review these studies. It will increase total cholesterol, it will increase LDL, but the total cholesterol to HDL ratio appears improved with lower carbohydrate intake, and clearly the triglycerides do as well. This is an adult type 2 study, specifically in type 2s, type 2 diabetics, again comparing a low carbohydrate diet to a high carb diet. And in this, they had similar amount of weight loss actually, They had similar amount of decrease in A1C, but the low-carb group had a definite improvement in terms of less medication use. So they were able to achieve the same degree of A1C reduction despite decreasing how many diabetic medications they were on. All right, this study is the last one for adults, then we'll go into kids to conclude the talk. This was really interesting to me. So classically, over the last few decades, we've used cholesterol panels, traditional lipid panels, as our best marker of cardiovascular risk. In recent, maybe the last 10 or 15 years, there's been a movement to not just look at the traditional LDL, total cholesterol, HDL, but look at the size of each of those subclasses. Look at the size of the LDL, look at the size of the HDL. And it's thought that if you have small, dense LDL particles, that is more atherogenic and more disruptive to your health than if you have larger, buoyant, less dense LDL particles. And that's really taken hold of the cardiovascular world as equally, if not more, predictive of heart disease. So I guess another way to say that is, it's not so much your cholesterol itself, it's the nature of what that cholesterol looks like and what that LDL looks like. This diet published back in 2006 by Krauss in Oakland. He looked at 4 different arms. And this is a smaller study. It's a less duration, but I think, for me at least, very intriguing. They had different amounts of carb intake as a percentage of calories per day. And then in the lowest amount of carb intake, they divided it into 2 groups. One was low saturated fat, one was high saturated fat. And look at the effect on some of the markers here. Triglycerides, clearly best improvement in the lower carb groups. This was not a severe carbohydrate restriction either. You're talking about 26% of your daily calories from carbohydrates. If you just do the math real quick, on a 2,000 calorie per day diet, 25% of that would be 500. If you're eating 500 calories from carbohydrates per day, that's I think 150. You can double check my math. I'm doing it in my head real quick, but I think it's 125 grams of calories per day, which is not that severe of a restriction, and something that I think is quite reasonable and feasible. So had the lower carbohydrate amount had the best effects on triglycerides, had the best effect on total cholesterol to HDL ratio. And this is one of the few studies looking at these different diets in a well-controlled way on size of LDL. And clearly, when looking at the size of the LDL, the lower carbohydrate diets had the best effect on the LDL diameter. And this is the type of cholesterol panel in our care clinic that we see all the time. It's this classic obesity or atherogenic dyslipidemia where there's high triglycerides, there's low HDL, there's your LDL and total cholesterol, really not that affected, largely normal. But when you do the subclasses, in this obese metabolic syndrome type of patient, the diameter of the LDL is much smaller in that type of panel. And so this is the patient that we see day in and day out in our care clinic, and it's the lower carbohydrate diet that has the best effect on the triglyceride, the HDL, and improving the size of the LDL, going from the small, dense LDL particles to the larger, buoyant LDL particles. So I want to briefly review some pediatric data. There's 3 randomized controlled trials I found. They're all small. Admittedly, they're all fairly short, but I think there's still this worry that, is this safe to do in pediatrics? Are we going to increase risk of heart disease? And these studies, at least for me, help to begin to answer that question, but I would acknowledge that absolutely more research is needed. This first one was published by Kara Ebling out of Boston 15 years ago. It was just 16 patients, so 2 arms, 8 each of 16 obese adolescents. And they compared what I would call a moderate restriction of calories, just 45 to 50% of energy. It's actually a lot still compared to a lot of the studies we've already reviewed. And that one was ad lib. again, versus a calorie-restricted, reduced fat diet, which was kind of the classic ADA, AHA, and USDA recommendations. And in this group, the low-carb group had a larger decrease in their BMI. Actually, the low-fat group had an increase in the BMI relative to the low-carb. And the HOMA-IR, which is probably our most classic marker of insulin resistance, was improved in the low-carb group versus increased in the low-fat group. This next one, a little bit larger, 30 obese adolescents, 12-week study. They compared a more severe carbohydrate restriction to less than 40 grams per carbs versus a diet, again, the classic less than 30% of energy from fat. In this group, the low-carb group had a clear improvement in their BMI versus the low-fat group. They lost, on average, 10 kilograms versus 4 kilograms in the low-fat group. The non-HDL, again, a very good marker, predictor of heart disease, had a better improvement in the low-carb group. And the triglyceride, even though it was not statistically significant, improved by nearly 50 points in the low-carb group, which I think is very clinically relevant. And again, it's the high triglycerides that we see so commonly in our kids in care clinic. And a much better improvement in triglycerides in the low-carb versus the low-fat group. Last one I'll review here. Again, a little bit larger. This is now 46 obese adolescents, a 13-week intervention. Again, a fairly severe carbohydrate restriction down to 20 grams of carbs per day. Again, against the classic low-fat recommendation. And again, the lower carb group achieves a greater reduction in BMI Z-score, in weight. They did not see any differences between the two groups in total cholesterol, triglycerides, LDL, insulin resistance, or glucose. They were basically improved about the same amount in both groups. Although, look at the triglycerides again, a really marked improvement versus 10 in the low fat. It didn't reach statistical significance in this small study. So a couple slides to close up, and I wanted to leave a couple minutes for questions. Based on kind of this newer data in the last 10 years or so and reanalysis of old data, how much has the ADA, the AHA, the government changed the recommendations? This is enormously controversial, this question. Old habits are hard to die by. There's been a huge swelling of support to take away these recommendations, but still groups that are kind of staunchly in the we need to decrease fat to decrease our cholesterol camp. And a lot has been at stake in reputations and careers and so on and so on. Enormous amount of industry, influence and stake in this. There's a whole nother talk in and of itself, some of the industry's input into this. And some of that has really been well documented in various books and in articles of late. But there really has not been a lot of change in guidelines, despite a lot of cries to the contrary. But a couple things have changed. They actually did get away from the recommendation, this is the USDA, to less than 35 to intake of fat as a percentage of total calories. They still absolutely recommend skim milk and low fat and to decrease fat, just that they don't give you a specific percentage anymore. And in the most recent ones in 2015, this was definitely in the news quite a bit, the old recommendation that was there for like 35 years to limit dietary cholesterol was removed. Again, I think just based on the data showing that it was not harmful. It's been known for a long time now that how much cholesterol you get in your diet has very little impact on what your blood cholesterol levels are. There's probably a small subset of people in which they're called hyper-responders that do have more of a impact, but for the vast majority of people, it simply doesn't impact your total cholesterol. So a lot of ongoing questions about this. This is, I think, very intriguing to me. As we see patients all day in our care clinic, I know the general pediatricians here and in private practice in the Phoenix area and really all around the country see kids day in, day out with obesity, with an atherogenic dyslipidemia, lipid panel, with insulin resistance, and the low-fat diets that we have traditionally been recommending over the past 30 years. There's just so much frustration that they do not work. And so I guess I just call your attention to the possibility that can we kind of have a mulligan with this and change our approach and do a lower carbohydrate approach. How much we should restrict, how severe, what's the content of the fat, in terms of saturated, monounsaturated, polyunsaturated. Those are all questions that absolutely need to be answered and need to be studied more. But we have in our care clinic developed some interventions for those that are interested to help them with more of the lower carbohydrate goals. And as we take the dietary histories on our kids in their care clinic, it's just really impressive to me, the amount of how much their diets are carbohydrate based and things that they may not even realize as being unhealthy to them, whether it's muffins or cereal or bread or so on, and maybe in and of themselves are not bad for you, but taken in whole, when you're getting your total daily carbohydrate intake into the range of, for adolescent males, mid 300s, and that's just a mean. Presumably those with obesity may have much higher than that. If you're getting your average, high 300s, 400s, taking that in, accumulation of all of those high carbohydrate foods that are such an integral part of their diet, is that what we need to be targeting as opposed to telling them, you should drink skim milk or eat less eggs and so on and so on. But there really is mixed messages. We're starting to focus more on the lower carb approach. They're hearing at a lot of their pediatric practices still, skim milk, lower fat, and so on. So our patients are getting different messages. I think there's a lot of room to look at this in a scientific way and potentially come up with better answers on what is a healthy diet. So with that, I'll close and certainly have, I think, a minute or two for questions. Yeah. Yeah, I saw that study too, the potential development of antibodies. Yeah, I think that's definitely a hypothesis and it needs to be looked at more. I think there's a lot of steps to say, okay, there are some people that develop these antibodies. Okay, what does that do to your cholesterol levels? Okay, next step, what does that do to outcomes? There's a whole lot of next steps that need to be done there before we form any conclusions. But it did appear that some people developed antibodies in that study. So that was my understanding of that. Yeah.
Calories matter. So this is what sort of happens is kids eat simple carbohydrates, they spike their insulin, they go fat, and all this stuff. Then you talk to them, basically say, what's the worst thing you've ever done? Try to lose weight. So they
Right.
restrict total calories to the best of their ability. They are motivated to lose weight. Then they sort of, it's hard to sustain, they sort of relapse. And then they try and do it again. And the second time is harder. So if you believe the simple thermodynamics, the calories in, calories out, based on metabolic rate, all you need is that. But my question is this, can the body downregulate its basal metabolic rate such that the next time you go on an 1,800 calorie a day diet, it doesn't work because now that's your new point?
Yeah, that question really is at the heart of everything I talked about, and the theory of lower carbohydrate diets. It's a calorie is not a calorie. Not that they don't believe in the second law of thermodynamics, but the question is, how does those calories affect your body, and what is your physiologic response to those calories? So I think one of the reasons that fat got a bad name in the first place was it has 9 grams of calories, I'm sorry, not 9 calories per gram as opposed to protein and carbohydrate, which is 4. So kind of, well, it's more dense in calories, so therefore it's going to lead to weight gain. But if you are more on this is insulin causing this side of view of this, your body, it's what are the nutrients, what are the calories that are influencing your body to store fat? And that's why those that are on the lower carb side of things say It's all about the insulin response. And if you can lower your insulin response, then it's not just a matter of simple calories. And that's why, again, so many people have trouble losing weight, as you indicated, on just decreasing your calories alone, and potentially why when you go ad lib calories in these randomized controlled trials and low carb, you actually have better results than the calorie restricted. I think it's a really intriguing finding that seems to be very consistent as I review all these randomized controlled trials, and will continue to be further studied. But so it's not so much a calorie is a calorie is a calorie. Of course, that's true on a level, but what are those calories doing to your physiologic response? What are they doing to the brain centers of satiety, and what are they doing to your hormone levels in terms of storing fat? So it's an extremely salient question in all of this, and people on both sides, but I hope that really continues to get researched. Yeah, we actually are running out of, so we'll do one more question. I know just want to be respectful of time. We'll do one more. Yeah. Yeah. Yeah, so one of the ways they assess risk in adults, and the cardiologists probably know this better than I, but the CAC, or the coronary artery scans to look at calcifications. It's not something that we're going to do in pediatrics because of the exposure to radiation. But in adults, it's definitely a well-known, well-studied marker of heart disease, and often is used as a subclinical marker of risk. But in a lot of these studies, they go beyond that. So you can look at the subclinical marker or the surrogate marker, but you can also look at heart disease and death. And I think as you look at, that's really what you ultimately want to look at, is not these kind of intermediary markers, but what are the ultimate events. And in a lot of the studies I showed, I really did want to focus on that as the most superior data to look at. We're out of time, so thank you guys